Hi, my name is Jeanette Lager. I'm the OBGYN Clerkship Director, and I've worked with a great group of medical students on this series about surgical procedures. For this C-section series, we're going to go over anatomy, talk about the detailed steps of the procedure, including instruments, to maximize your learning during this case. There are 5 things that I think are important to know about C-section, among many, many other things. So in order to have a great experience during the C-section, it's important to gown up, make sure you get booties, because sometimes there can be a lot of fluid. So sometimes it's even the high booties that you should put on. Introduce yourself to the surgical staff and write your name up on the board so they know who you are. And then find the opportunities to participate in the C-section. That can include using the suction, bladder blade retraction, whenever you see someone tie a knot to grab the suture scissors, help them to maintain a clear visual field, and sometimes suturing and knot tying. Make sure before you come into the operating room that you've practiced your knot tying. Number 4, be enthusiastic and ask questions about the procedure. But keep in mind, number 5, that the patient is usually awake, they have an epidural in place, and they can hear everything that you're saying. So ask appropriate questions, and if there's other questions that you might not want to ask at that time, you can always ask them later. Thank you, and I hope you enjoy the videos.
Hi there, my name is Rachel Levy, and I'm a 4th-year medical student here at UCSF. I'm going to be talking to you today about cesarean sections. After watching this video, I hope that you will understand the indications for C-sections, consider some advantages and disadvantages, recognize anatomical landmarks, the surgical instruments used in the procedure, be familiar with a preoperative checklist, and the general procedure itself, and some possible complications of the procedure. Most of all, I'm hoping that after watching this video, you'll feel a little bit more confident scrubbing into your first C-section. So first, a little background information. As you probably already know, a C-section is the delivery of a neonate through incisions through the patient's abdomen. Taking a look at the graph on the right, you can see time on the x-axis and rate of delivery in percentages on the y-axis. As you can see, the rate of total C-sections, as well as the rate of primary C-sections, has increased over the last 20 years. While in contrast, the rate of vaginal birth after C-section, or VBACs, have decreased over the last 20 years, but might be rising now. Like many things, the rate of C-section varies by state. In 2016, Utah had the lowest rate at 22%, and Mississippi had the highest rate at 32.9%. The story behind those numbers is complex and is impacted by the indications for C-sections. The National Organization of OBGYNs, or ACOG, lists labor arrest, non-reassuring fetal heart tracings, and fetal malpresentation as the main indications for C-sections. I've listed some other indications on the slide here. During your 3rd year OBGYN rotation, you'll be following patients through the labor process. Your team may discuss the potential need for a C-section, so it's important that you're familiar with the indications. Also, before you scrub into any C-section, you should definitely know the indication for that particular patient. While there are some hard and fast indications for C-section, it's important to consider the unique circumstances of every patient. In order to make a decision, we have to weigh the risks and benefits. So first, let's talk about the benefits. A C-section can be scheduled, and this can allow for important people to be present and can also allow the patient to manage a busy work or personal life. A C-section can also be administered before 42 weeks gestation to avoid a post-term delivery, which is dangerous for both the patient and the fetus. Unlike a vaginal delivery, a C-section avoids injury to the perineum, which can be associated with both urinary and fecal incontinence. Lastly, a C-section can be used to progress labor more quickly and can also allow for management of conditions that were listed on the previous slide. Now let's talk about the risks. A C-section is a major abdominal procedure and therefore has the risks of any major surgery. This includes infection, major blood loss, DVTs, complications from anesthesia, injury to abdominal organs. For baby, the risks include a slightly delayed skin-to-skin, potential for injury or laceration during the procedure, and when born by C-section, a neonate does miss out on some of the benefits of a vaginal delivery. Because the lungs of a neonate are not squeezed through a tight vaginal canal during a C-section, respiration might be slightly delayed. And a neonate born by C-section is also not exposed to vaginal flora, which may aid in the development of gut microbiome. A C-section also leads to a scar in the uterine wall, which can predispose a patient to having uterine rupture or different placental abnormalities in a subsequent pregnancy. And both of these things can lead to significant blood loss and even hysterectomy in a very severe case. Finally, compared to a patient who undergoes a vaginal delivery, patients who have a C-section generally have longer hospital stays. So here I've listed some of the high-yield surgical instruments for third-year medical students. Here we have the bladder blade, and that's used to pull the bladder inferiorly and open up the surgical field. The Army-Navy and the Richardson retractors are also used to open the surgical field during a C-section. The bandage scissors are used to cut the umbilical cord after the delivery of the neonate. So not pictured here are suture scissors and the needle driver, which you may use if you're asked to close an incision. Also keep in mind that the names of these surgical instruments may vary across institutions. So before we talk about the procedure itself, it's important to review some of the anatomical landmarks involved in a C-section. So 3 abdominal muscles, the external oblique, the internal oblique, and the transversus abdominis are important for you to know. Those 3 come together to form the rectus sheath. The anatomy of the rectus sheath differs above and below the arcuate line of Douglas, which you can see here in green. So just to orient you again, this dashed line is the arcuate line of Douglas. Above that line, you can see a cross-section where the 3 muscles come together to form the bilaminar aponeurosis, both anteriorly and posteriorly to the rectus abdominis muscle. Can you remember which 3 muscles come together to form the rectus sheath? That's right. It's the external oblique, the internal oblique, and the transversus abdominis. Below the arcuate line, you can see in this cross-section here that the rectus sheath is only anterior to the rectus abdominis muscle. This means that the rectus abdominis is directly anterior to the transversalis fascia, shown here in purple, and that the transversalis fascia is directly anterior to the parietal peritoneum, shown in orange. It's also important to know the anatomy of the internal organs for a C-section, and if you'd like to review that more, I recommend you find Gabriella's video on myomectomy. That's the end of this video, and in the next video, we'll talk about the procedure itself.